everyone. Thanks very much for tuning into this presentation. My name is Geoff. I'm a research associate at the University of Bath in the Institute for Policy Research. I'm going to talk today about interventions for people who use anabolic steroids. Firstly, quite broadly, talking about the state of the evidence base, what we know, what we don't know, perhaps where some of the gaps in that evidence base are, and then moving on to talk specifically about treatment interventions. To continue some of the themes from the first part of the talk. So I've put quite a lot of thought in the last few years around anabolic steroid interventions, and I've been recently thinking about what specifically really it is that we're interested in when we talk about interventions targeting people who are using steroids or trying to change something to do with steroid use. And this is all very, very sort of broad. This is certainly not a kind of a conclusive set of questions. But for me, these four questions are perhaps the ones that we're perhaps most commonly interested in. So how can we prevent steroid use? How can we reduce the harms associated with that steroid use if for someone who does go on to choose to use anabolic steroids? How can we bring about and maintain behaviour change? So moving somebody from that sort of that user status towards a non-use, being a non-user, and then keeping that going. And then fourthly, how can we treat the sort of the harms associated with steroid use? So we know we have an increasing body of evidence that suggests that there are a range of physiological and psychological harms, whether that's sort of short-term or longer-term associated with steroid use. So how can we sort of treat those harms and support health amongst people who do choose to use steroids? And it kind of strikes me that there's these underlying issues across all of those different areas of interventions, and that is this big kind of really big question of what are the opportunities to deliver interventions, and as part of, similarly, kind of how can we engage with people who use anabolic steroids. So it's these kind of questions like, well, how can we increase engagement between people who use steroids and health professionals or health services? We know that often that engagement doesn't tend to be particularly high. So how can we kind of increase that? Where we do have engagement, how can we deliver effective interventions in services and in sort of healthcare settings? And the other side of that, how can we provide information and support outside of healthcare settings as well? So it's kind of question of, well, we might start to understand what we mean by interventions and what kind of interventions work, but how can we actually be in a position to deliver these? And that's, I think, relevant to treatment, as we'll come on to later, in terms of what are the opportunities for actually delivering some of these interventions that we want to. And I find it interesting to look at, think about this in terms of the size and the quality of our evidence base. And what we've got over the past 20, 25 years is a real increase in the amount of evidence that we have around anabolic steroids that together, I think, establishes this need and justification for interventions of the types I outlined before, so prevention, harm reduction, and treatment. And so we have a growing body of evidence that has we've learned a lot from, in terms of things like risk factors, characteristics of people who are using steroids, their sort of preferences, their experiences, their motivations, all these sorts of points, as well as some of the harms perhaps. And yes, so that this is still an evidence base that can increase, but I think we can agree that this is a substantial evidence base in which to say, yes, this is where we might need some sort of interventions. In contrast, we have this really small evidence base, however, which is the studies of interventions themselves. And really that is almost entirely made up of studies looking at prevention efforts. And so the evidence base on interventions has not kept up with the evidence base around our kind of understanding around anabolic steroids and the harms and why we might want interventions. What do we actually want to find out about interventions? What do we need these studies for? Yes, of course, a big question is around what is effective, and that sort of traditional approach of evaluating intervention to find out if it works or not. Does it bring about the outcomes we want? But what we need to know goes a lot beyond that as well, which I think sometimes gets a bit lost. And this kind of, I guess it's a question there. If you look at realist sort of evaluation, this is a very similar question to what you're finding in that sort of realist approach. Kind of what works for whom, where, and why. So it's really around, yes, we want to know what is effective and what isn't, but also what will affect the implementation of these interventions. And it's these sorts of questions like I've listed here around what's kind of going to be acceptable to people, what is possible to deliver. If we deliver an intervention, what are the sort of the spillover effects or the unintended consequences of these interventions are going to be. And this is sort of inspired by sort of implementation science field. Is really trying to understand not just effectiveness, but these other types of questions. And this is where we need different types of evidence. So when we talk about evidence to inform interventions, we're not specifically thinking only of these sort of nice controlled studies where we compare an intervention with another condition and see what the outcomes of that are. We're talking about sort of evaluations of services being delivered to people using steroids, so qualitative studies looking at the perspective of users, people delivering interventions in either health staff, in services, or any other settings. And asking those questions to try and find out, well, what do people want? What is feasible? What's the sort of the barriers to delivering some of these interventions? And all of this is really missing from the evidence base at the moment. So in terms of our studies of interventions, then what we have at the moment is evidence from really over around 30 years worth of primary prevention interventions, evaluations of primary prevention interventions, usually based within schools, in school sports settings typically, trying to reduce the chance that people will, these young people will go on to start to use steroids later in life. It's a very mixed evidence space. It's quite an incoherent set of studies really that don't really follow on from each other, or it's quite hard to know on for what reason they've been developed, whether they're sort of replicable, and the sort of implementation side of it isn't really there. And so while we can learn lessons from this evidence base, it's perhaps got a sort of mixed use for us really if we want to know around, well, what should our prevention interventions be about. And there's an awful lot missing from this evidence base, if we want to go on to develop interventions. Not a lot to learn from in the evidence base in terms of sort of targeted prevention approaches around engagement, how to sort of induce behaviour change amongst people who are using steroids, whether that's to adopt sort of more harm reducing behaviours or to sort of move towards cessation, or around treatments. There's very little to go on here. And interesting though, I think, we know that all of these types of interventions are going on in the community. For example, in the UK and other countries, we have an established needle and syringe program, which intends to engage with people who are using steroids. We know that in parts of the UK, people who use steroids are really significant client base for lots of needle and syringe programs. We have very little evidence that actually tells us whether these approaches are effective or not, or how to improve or their effectiveness. Some other examples we have, we know of gym-based interventions in the community, for example, in the Nordic countries, but again, we lack the evidence on whether they work or not, and what it is about them that means whether these interventions are likely to work or not. And so we really need more studies of these existing approaches to help us understand them. And just to highlight again that, yeah, we're talking about a lack of studies of whether these interventions are effective or not, and also of their implementation. So yes, do they work, but also why do they work and why not? What are the important factors there? So let's move on to the sort of the main focus of this presentation, which is going to be around treatment interventions. And it's an area that it's interesting to me because of all the different sort of those four intervention areas, I think that treatment's probably the one that I've up until last year spent the least amount of time on. Why I find it interesting is that I think and this is all very tentative, as well as being, as an excuse to put a dinosaur into the presentation, which I always will when I can. I actually wanted to make this point that these are kind of quite tentative conclusions for me, and that I'm not completely sure about them. But for me, it seems that treatment interventions is just perhaps the intervention areas where I think there's the clearest aims for what we want to do, and the clearest populations for who we want interventions to reach, to engage with, and to affect. Um, Also, possibly the least evidence of effective approaches in the evidence base to date, anyway. So it's an interesting area, I think, to look at. Again, this isn't anything that's sort of published or has been backed up with much science, but this is how I kind of categorize treatment interventions in the work that we've been doing, which I'll go on to talk about briefly. But and similar to sort of models of drugs interventions for other types of drug use, I think. Whereas where I think that treatment interventions can be kind of fit into these different categories which really do overlap as well. When we talk about treatment for people using steroids, we could be talking about this sort of behaviour change approaches, so motivating and supporting someone to move from that sort of user status towards stopping using their anabolic steroids. As part of that, supporting their recovery, so helping that cessation become a long-term change, and preventing sort of reinitiation as well. And this might be referred to as sort of recovery. I'm not sure about some of the language in this, but I'm trying to make it consistent with what we might use in other types of drug use. And then again, associated with that, we have these sort of treatment interventions in terms of treating the harms associated with steroid use, whether that's these acute or longer lasting psychological or physiological harms. And obviously, again, these three areas overlap. So where we are motivating and supporting cessation, we're also thinking about supporting that in the long term. And as part of that, there's likely to be some sort of treatment in terms of treating harms as part of it. So I don't see these as three independent areas, but something we have to think about all as one package. So we undertook a study, a sort of systematic scoping review, which looked at what is the evidence on treatment interventions. And we tried to find what is known about interventions that aim to support and achieve cessation of anabolic steroids, and interventions that treat and prevent associated health consequences. So really those three overlapping areas from the previous slide. This was carried out with colleagues, at the time we were at Liverpool John Moores University, so with Mary Claire Van Hout, Joe Tay and Jim McVeigh. And the paper, I've linked the paper here if anyone is interested. It's an open access article. So I'm not going to talk about the details of the paper at all today. And in some ways the detail is, I don't know, of limited interest, but the messages I think in it, I think are interesting anyway, and hopefully you will do too. So these sorts of questions that we were trying to kind of really find out was around, well, what sort of treatment interventions are effective? How can they be delivered? How can we engage with people using steroids? What sort of settings should they be in? These are all the things we wanted to find out ideally through this review, in terms of how can we really, that core question of how can we support and achieve cessation of anabolic steroids. I'm not going to talk about the detail of this. It's the afternoon session, and the last thing most people are probably going to want is around detail of a systematic review methods. I could talk about it all day, but I know that not everyone is quite as infused. But I wanted to highlight a couple of points, which is that we included any study within this review that reported a treatment given to people who use anabolic steroids in response to a harm that was associated in that study as relating to their steroid use. And that's the important point, that we made no attempt to sort of understand whether that harm really was as a result of their steroid use or not. But if it was picked up in the study that this was treatment that was needed for a harm that was relating to steroid use, then we included it. And we actually found what sounds like a lot of evidence, so 109 studies to include within this review. But the real problem with this was that all of these studies were case reports. So they were all examples of individuals who had who experienced harm and required some treatment for it. There were no sort of controlled studies at all, no qualitative evidence to sort of help us understand that implementation side of things. And if you've ever looked at sort of published case studies, so these are published in all sorts of different, really sort of quite technical or medically specific journals. And what you find is that there's a great diversity in how they're reported. So in terms of the types of evidence that they actually give within these case studies, it varies so much. And typically they tell you a bit between a very little and a lot in these sorts of areas, around the detail around the harm this person's experiencing, around the characteristics of the patient, around their steroid use, the treatment they received and the outcomes of that. And all of those different factors varied so much between the different studies. So it's very difficult to make any type of comparison in terms of what's effective, what's not, and why, because that's not what the case studies are designed to do. So this isn't necessarily a criticism of the studies, it's just the nature of that type of evidence isn't really conducive to understanding the sorts of things we need to understand if we're going to be able to build up this evidence base. Just to highlight some of the findings from this review and then put them in a bit of context. So our main question was around, well, what sort of interventions are effective to support and manage cessation from steroid use? And without going into the detail, essentially we found no evidence about treatment following a diagnosis of anabolic steroid dependence, or about interventions to motivate or support cessation. And we know that we put some detail in the paper about a few studies that kind of touched upon this, but there's nothing for us to go on. In terms, if we wanted to develop a new intervention, there would be nothing here to help us to do that. What we did find was a lot of different interventions to treat a range of harms or side effects that were associated in that paper to be something to do with that person's steroid use. But what does that actually tell us? Well, the short answer is not very much. And the slightly longer answer is that these studies together tell us that people who use steroids sometimes will need treatment for a range of associated harms. And we kind of categorize these according to the categories in the table here. So you can see the types of harms that were being reported. Sometimes these harms can be very serious. I mean, there are examples of patients who unfortunately died, and others who had quite long-term complications. But generally speaking, these harms were successfully treated using a variety of treatments. We didn't make any attempt to try and sort of establish whether these were appropriate treatments or not. That would be well beyond, well, certainly beyond my knowledge anyway. But there are a lot of different treatments are attempted for all these different harms. And what kind of perhaps most interestingly for us, these medical treatments don't appear to be accompanied by any additional interventions. These kind of behaviour change or harm reduction or any kind of engagement of interventions that we might have hoped to find. Because if we come back to those kind of key questions about interventions, for me, this underlying question is one around how can we actually, what opportunities do we have to engage with people who are using steroids? How can we increase the delivery of interventions? How can we, if we find an appropriate intervention to support harm reduction or cessation, what's the best way of reaching people to do that? And we know that for a variety of reasons, therefore, this engagement between people who use steroids and health professionals is rare, certainly in the UK and as far as I'm aware internationally as well. And there's lots of reasons for that that are sort of beyond the scope of this presentation to go into. And I'll give some examples here of some opportunities to provide interventions as part of these sort of treating harms associated with steroid use. And I recognise that this will vary a lot. And there'll be times when this is appropriate to do and not, depending on the sort of the severity of the condition, the setting, the sort of the detail of the person who's engaging with that steroid user. But there's some examples of the types of interventions that we might have hoped to see delivered alongside sort of the treatment of specific harms. But what we found then is that there was very little evidence along studies of engagement with users about their steroid use alongside any treatment they received. So we found a couple of studies that mentioned that they gave some brief advice to stop using steroids as part alongside with that, along with the specific treatment given. No understanding of whether that's going to be effective or not. And from what we know about just telling people to stop doing something, it probably is unlikely to be that effective. But no evidence of any sort of specific harm reduction interventions, no evidence of any additional investigations into the possible health harms that that person might be experiencing, apart from the one they've received that specific treatment for. The big caveat, I suppose, it's just worth flagging is that just because they didn't report this engagement, it doesn't mean it didn't actually happen. It wasn't the focus, often wasn't that person's steroid use within these studies, but it probably is correct to say that in generally this didn't happen, and if it did, then well, nothing's been written down about it. We've got no evidence to go on, so it doesn't help us at all. Just to finish off with a couple of examples of how this engagement might be missed. For example, then we had 25 cases within this review of patients given treatment for some hepatic disorders. In 12 cases, they had recently started using steroids themselves. We know this is a key time to engage with people and when they might be more susceptible to behaviour change messages or harm reduction messages. So this would have been a good time to try and initiate some engagement about that sort of their behaviour and their choices. At the other end of this, 5 of these 25 patients are reported over 5 years of steroid use, so quite long-term users. And at that point, we might expect to see some other harms coming through. There's an opportunity to test for other disorders, as well as promoting behaviour change, promoting harm reduction. But again, no evidence of this. In cases of treatments given for harm associated with injecting complications, so people who had infections or abscesses that required treatment, you'd think this would be a good opportunity to provide interventions on injecting practices, some sort of delivering some kind of harm reduction information. But again, no evidence that this took. Just to finish off then, some what I think really are the key points of interest coming from this, which is that overall there remains little evidence to support the development of evidence-informed interventions really relating to any types of interventions, but specifically around motivating and supporting cessation or management of symptoms following cessation. So what we might think of therefore as treatment interventions. I think it's clear that alongside medical treatments for the many harms associated with steroid use, there is clearly an opportunity to engage with users, so leading to further interventions. As far as we know, that isn't likely to be happening at the moment, and if it is happening, we really need evidence on this, and we need studies therefore of all types to examine all types of anabolic steroid interventions that are currently being delivered, and that's thinking about whether they work or not and these issues around implementation. And if we can do that, then we'll start to build a much more meaningful evidence base that will be useful for anyone working in this area. So thanks very much to Jim and colleagues for inviting me to give this talk. Thanks to everyone for listening, and look forward to the Q&A. Thank you.